Hello, rheumatology fans. Welcome to Chewing It Over. As you will notice, I am not Jack Chew. It's Jack March here today. I was supposed to be speaking to the wonderful Jack Chew, but unfortunately he was unavailable at relatively short notice. So the good news is we are going to do an Ask Me Anything, all about rheumatology. And hopefully there will be some interesting questions and some interesting answers for us to get our teeth into. And it'll be a good opportunity for me to flex my question answering brain cells, let's say that. And hopefully it'll be a good distraction from some of the things that have been occurring around the world. But it will be Christmas soon, so hopefully everybody is ready and raring to go for the old Christmas time. Hopefully there is some people in the old ether, and I'm not just talking to myself. So if someone could give me a thumbs up in the chat function to let me know you can hear me, then that would be wonderful. Please do pop any questions into the chat, and I will endeavour to answer those as we go along. And if you're listening to this back in the I suppose in the future for us now, as I record this, then please do feel free to get in touch on social media with any questions, and I will endeavour to answer them in various other ways as well. Of course, Twitter, Facebook, Instagram, etc. If you just type in the rheumatology physio in there, then you can usually find me. I come at the top. So if anybody is tuning in, can you just give me a thumbs up in the chat function to make sure that I can hear you? Sorry, that you can hear me even. It'll be interesting turn of events, that you can hear me, and then pop any questions that you have in there for me, and I will crack on with answering them. I've got a couple that have already been sent in from my social media posts that I put out a few hours ago, saying that I was going to be doing this Ask Me Anything. The first one is from Adrian Davies on Twitter. Thank you for getting in touch. And he asks, when assessing for enthesitis, which enthesis would you normally assess? And he goes on to caveat that just close to the presenting condition, or would you also look at some of the more commonly affected sites? Cheers. Cheers to you, Adrian, for dropping the question in. So there's two sort of directions we can go in this in talking about enthesitis. So we'll talk about peripheral spondyloarthritis to begin with. So we're talking about something like psoriatic arthritis, or maybe an enteropathic arthritis related to the gut, where the primary disease process, let's say, is a peripheral enthesitis, and that's likely to be why they're coming in to see you as an MSK therapist. So in which case they're presenting with issues, and I'm guessing we're already thinking there might be something inflammatory going on. So they've got some comorbidities that we're interested in, like psoriasis or Crohn's disease or colitis. In which case, when we're starting to look at the entheses, then what I would suggest is that we are looking at the symptomatic sites. So this would be the let's say it's the Achilles, so we're looking at the heel for that insertional enthesis, and that is the most common location to get enthesitis, would be in the heel. So either the plantar fascia insertion or the Achilles insertion. So I would assess there. It is a bit difficult to clinically differentiate out enthesitis from a load-based tendinopathy, although some of the load-based tendinopathies often tend to be mid-portion rather than more insertional, but plantar fascia is more difficult. So Achilles, it might be mid-portion, and then it's less likely to be enthesitis because obviously it's not down at that enthesis right in the heel. But if it's plantar fascia, so more under the base of the heel, then it is more difficult. Sometimes when people present, they will have a very red, hot, angry insertion, and then it is easier to consider that to be a likely inflammatory enthesitis, in which case then that does make life a little bit easier for you. But quite often that won't present like that. And recently did read a paper on psoriatic arthritis, and they tend to not present with such overtly inflammatory symptoms, which is not very helpful at all. So if someone is presenting with an insertional heel pain, then I would be assessing that as normal what are the load-based factors, etc., etc. Anything else that might contribute to having an insertional tendinopathy. It gets more interesting if they've obviously got bilateral symptoms, or if they don't have any load changes in recent history. That means that they that hasn't been seen as a trigger, but also multiple tendon sites as well. So if you've got the heels involved, maybe the elbows, maybe the lateral hip, something like that. So you're jumping around the body locations, either at the time or in the past medical history. Then you can start to think, okay, how likely is it that this person's had 4, 5, 6 tendinopathies, and how is it more likely that they might have had a more systemic inflammatory pathology? So that's what I would start to do with the peripheral type patients. Richard Saxton's just tuned in here, and he says, "Hi Jim." Hi Richard, thanks for tuning in. My colleague there at Choose Health. So the other option that we're really looking at here is in our axial patients. So these are patients with back pain. So when we look at data relating to axial spondyloarthritis, so conditions like ankylosing spondylitis and psoriatic arthritis patients with axial symptoms, then quite a high proportion of them will have a peripheral tendon issue as well. So again, at that point, then we will be looking at back pain plus the tendon problems. And again, as I've already mentioned, the most likely place to see that is the Achilles or the plantar fascia insertions, so at the heels. But there is still a high incidence in the elbows and the lateral hip. So we're looking at medial tennis elbow and golfer's elbow. And if anybody can tune in and say epicondylopathy for me a few times, I'd be really grateful. So we are looking at those sites, and again, we're looking at history of those, or coinciding with the back pain as well. And it can be either, so that you might have a preceding tendinopathy that might actually have been the first symptoms of the spondylitis. So it's important to go into depth there. And again, you want to be asking similar questions. Was it that there was a change in load and that was a clear trigger for bringing on those symptoms, or was it completely out of the blue? Was it after an illness, an infection? These kinds of questions are what we're really interested in. Of course, we're still going to go into family history, other interesting inflammatory problems, and we've plenty of information which I can direct you to if needs be around what those comorbidities look like. We can start off in spondylitis, for example, using the SPADE tool as a good list there of how to ask those questions and which questions to ask about comorbidities. It gives you a likelihood on that patient having a spondylitis. So really, the first instance with enthesitis, we're going to follow the symptoms. But in the second instance, what we're going to do is we're really going to dig deep and ask those questions about whether there have been any insertional tendinopathies in the past. Did they react like you would expect to loading programs? Did they have an onset that you would have expected, or a progression that you would expect? And what happened with that? And then you're piecing these things all together. And then, of course, there is that final option where it might well be there's this very, very red, hot, angry heel that looks very, very inflammatory. The other enthesis points, like the elbows and the lateral hip, they don't tend to give that very red, hot, angry set of symptoms, because they are that bit deeper under the soft tissue. So it tends to not be like that, and they are smaller areas comparative to that large insertional heel area. So hopefully that's put some good meat onto the bones of enthesitis. A couple of questions that I've been put into recently, which are along similar lines, but with regards to psoriatic arthritis, is around nails and nail beds. What are we referring to rheumatology? What are we not referring to rheumatology? And it really is, my answer to this is really trying to build up this clinical picture and trying to stack your pieces of information one on top of another until you're confident that you're making the right decision. The concern here, of course, is that there are components to the disease that we as MSK therapists are not particularly well equipped to assess, and the nails would be one of them. Nails and skin, psoriasis particularly. Certainly I don't feel confident with assessing those, and it's something that is a real challenge. And so if we don't have that component of information, that we're unable to create that full picture of a reasoning program and process, and that's going to impede us on making the right clinical differential diagnosis. So it's something that we really need to start considering in these tendinopathy patients and in inflammatory spinal patients, is whether, if they've got a diagnosis of psoriasis previously, fine, that's great. They've got a bit of dry skin, then what is causing that? Do we think that's psoriasis? Do we not? And certainly I'm not the person to be trying to sort that difficult situation out. But if they have this diagnosis of psoriasis, are there nails involved? And what are those nail changes? And it's really important that we are aware that those are something that can happen, and the fact that nail changes are associated with a much higher likelihood of having a psoriatic arthritis. So if we go back to our building of a clinical picture, then you would have some weight in your clinical reasoning added to having psoriasis, or a past medical history of psoriasis, or current psoriasis. You would add much more weight to having psoriasis with nail bed involvement, so cutaneous psoriasis only versus cutaneous and nail bed psoriasis. And it's going to be much higher a much lower threshold for referral, a much higher index of suspicion if that patient has those nail bed changes. And understanding what those look like and having seen them before is a real challenge because we tend to not pay too much attention. So this is what brings me to the sort of crux of this question, really, which is similar to the one we had before. Are we looking, if we've got upper limb symptoms, are we just looking at the upper limb nails, or the other way around, lower limb and lower limb nails, or are we looking at the other limbs as well with regards to nail changes? And the answer is yes, I would be looking at all of them to make sure that we're fully assessing the nails of that patient. So if you've got someone who comes in with bilateral tennis elbow, for example, and psoriasis, then it will change, or is likely to change, your clinical reasoning thought pattern if you then take their shoes and socks off and they've got nail bed changes in their feet, which you may not see in the fingers. That's not necessarily going to happen. That's in every single nail. So I really would encourage you to put that into practice as something that you start doing with tendon pain patients, is that you're assessing all of their nails and making sure, even if it's upper limb, you're still getting their shoes and socks off and looking at their lower limb nails, or the other way around. It can be a little bit of a weird setup to the conversation, but there are other things that are more embarrassing that we have to ask our patients, or perceived as more embarrassing that we ask our patients. So, I frame it just like, if it's psoriasis, it's much easier, because if they've already got a diagnosis of psoriasis, I'll just say, psoriasis can affect any of your nails, and I need to check your toenails to make sure that that's not happening there. That's easy, but I would still be doing it even in those patients without a diagnosis of psoriasis, because these patients may have very mild psoriasis that they've never sought medical care for. But the other thing is that somewhere around 15 to 20% of psoriatic arthritis patients will get musculoskeletal symptoms or tendinopathy or joint problems before their psoriasis actually onsets. So they might have had this tendon pain for quite a long time, and then their skin issues begin, or their nail issues begin, and they're seeing you a little bit further down that line. For example, they've been to orthopedics, they've been to the GP, they've been to various locations, and they turn up with you after a period of time. They might even be third, fourth, fifth physio that they've seen, or fifth MSK therapist they've seen, and they've developed these symptoms as time's gone on. And so we're building that clinical picture as things change. So it is really important to make sure you get into the habit of doing that and understanding what it is that you're looking for. And there are some characteristic changes of those nails that you want to be checking out. There are some pictures on my website you can find, but if you Google psoriatic nail changes, then those kind of pictures will come up. They are quite characteristic, even if they are quite difficult to assess from a MSK therapist point of view. It's quite challenging. I suspect if you start working in somewhere like a first contact practitioner role, and you're getting a lot of these sort of unfiltered patients, I should say, unscreened patients coming through, and you're really thinking, oh, I'm just not confident with these skin changes, not confident with nail bed changes. And there are obviously other things that occur at the nails and the skin. It might well be worth going and sitting in with dermatology for a day to understand some of the changes that occur there, or even into rheumatology if you thought that might be more appropriate, and ask specifically if they've got any psoriatic patients that you could have a look at their nails and just assess that, so you know what you're looking for, because it really is something that once you've seen it, then you know what you're looking for, and you can rule other changes like fungal nail infections out, which is a real said and it's certainly, like I said before, certainly not within my skill set. But it's this building of this clinical picture, this evolving sort of clinical reasoning process that we're building up as we're going, that we're going to try and do, because this is where you go, well, where is my line for referring to rheumatology? And it's going to make swings and roundabouts depending on what you find and what you weight differently. And that's really challenging, especially in these times. At the moment, COVID is still hanging around and still causing us problems, and the backlog of sort of rheumatology waiting lists and all different waiting lists is still problematic. So we want to be judiciously referring. We don't want to be over referring when we don't need to, but also we can't hold these patients back if they need to go to rheumatology. So the more detail we can get about our clinical reasoning process, the better referrals we can make, then the better we're going to do. So again, I would just direct you to the SPADE tool. You just need to type spadetool.co.uk into Google. That's a really helpful resource for assessing spondylitis patients, or the possible spondylitis patients. It has a whole checkbox list of all the things that can be implicated, and you just tick the ones that your patient has and click show results, and it will give you a likelihood of how likely that patient is to have a spondylitis and whether you should refer them on to rheumatology or not. So a really useful way of backing up your clinical reasoning. So we're cracking through it. We're just over halfway through this. Any questions that you do have, please do put them into the chat function. Really interested in answering your questions here on Ask Me Anything, and I'll try and get to as many of them as I can. Another question that I had come in was regarding female presentations of axial spondyloarthritis, and this was a little bit off the back of my recent podcast I did about pregnancy and ankylosing spondylitis, and what we really need to understand is these differences between women and men when they present with predominantly axial symptoms. So we are looking at about equivalent numbers, where women are going to get the same amount of axial spondyloarthritis as men are. It's not a male-dominated disease. We need to get rid of that belief system. But what we know with women is that it's much harder to recognize and diagnose, because what tends to happen is they tend to present with less inflammatory sounding symptoms. So they tend to have less of the early morning stiffness of the spine, less of the activity related improvement and rest related deterioration, a bit less of the night pain, these kind of symptoms. They also tend to have more widespread pain. So they report trunk and buttock pain rather than spinal pain, and deep sort of gluteal pain is real problems, that it's just not so specific. And then when we go into investigating them, their blood tests tend to be a little bit more equivocal as well. So there's a slightly lower rate of HLA-B27 positivity, a slightly lower rate of the inflammatory markers being positive, ESR and CRP, but also they're far less likely, much less likely to get changes on X-ray in their sacroiliac joints. So someone firing off a sacroiliac joint X-ray, they're going to pick up a few men where they won't pick up any women. So we're still seeing this delayed diagnosis for women as we go down into extended periods of time, which is problematic, because then when you follow those patients through, those female patients through, they actually tend to report a higher disease burden, more widespread pain, and more work productivity loss than men do. So it's certainly not that their disease is easier or lesser than men's is, just despite the fact they don't get these changes on X-ray. They're not getting fusion or erosions of the sacroiliac joint. They're not getting fusions of their spine in such numbers that men do, but they're still, their functional loss is equal, and their medicine loss use is equal as well. So they're certainly not getting a lesser disease. So we still need to be picking these ladies up. And this comes right back to the first question we got asked about entheses. And if you've got a lady with inflammatory sounding back pain, she's more likely to have a peripheral manifestation. So she's more likely to have a peripheral enthesitis than a man is. So you're looking for those peripheral tendinopathies. So real challenge. I'm hoping to get a podcast out on that with a rheumatologist to get some real good detail. Got a question here from Louise Huntley. Something certainly that I don't specialize so much in these days, about hypermobility. So my general approach to hypermobile patients, and I'm assuming, Louise, you're asking when do we need to refer sort of outside of physiotherapy or outside of musculoskeletal practice. I'm swinging a guess at that. So for more of a medical management process. So if it's my usual approach is, if the patient has hypermobile joints, and this is the main issue, Louise says yes, the outside of physio. So if the joints are the main issue, then physiotherapy really is the mainstay of treatment. We need medical input a lot for some management and also investigations for the less musculoskeletal manifestations of hypermobility. So what we're really looking for is things like stretch marks and getting dizzy, changing position, which can be something associated with a problem called POTS, which postural orthostatic tachycardia syndrome. Any problems with the gut, and especially if they're losing any weight, those kinds of issues. Then we're starting to look at, okay, do we need to refer these people outside to their specific medical disciplines for further investigations? And anybody with severe disease as well, then multiple extra-articular manifestations as well. There are clinics in London and elsewhere where they'll do specific testing for Ehlers-Danlos syndrome as well. But it becomes really quite difficult because it used to be, and in some places still is, that rheumatology would be the unifying sort of place. But unfortunately, rheumatology, there's not really very much for the rheumatologists themselves to help the hypermobile patient with. It's often multiple joint pains, but from a medical point of view, the rheumatologist is really sort of quite hamstrung. It's not a lot that medications can do outside of POTS. The medications can help there, but the rheumatologists can rule out other potentially important diseases, but really hypermobile patients unfortunately don't really fit anywhere. So it's ideal if you've got somewhere locally which specializes in hypermobility, a physiotherapist or an equivalent GP with special interests that might specialize in managing hypermobile people, so that they can centralize sort of the process, provide them with the exercise and advice and pacing and all that kind of thing that those patients need. And then from that sort of hub, refer to cardiology if needs be, gastroenterology if needs be, out to specialist centers for genetic testing if needs be, but they're a long wait as well. So it's a really challenging area, really difficult to manage. My personal way of managing hypermobile patients is to keep them self-managing as much as possible, except for those extra-articular manifestations where they need specialist input. And that's sort of my my best advice, really. Hopefully that's answered the question there, Louise. But they are a really challenging subset of patients because it's this this problem that it's not generated by an inflammatory process. It's not it's just a way that the body generates collagen. It's just really stretchy, so there's nothing medically that you can do to sort that problem out. That's just something that's going to occur. So they really need lots of muscular strength and muscular ability to hold their joints stable, and being active as much as possible is going to be really beneficial. And that really, I've seen in the past, that really impacts those extra articular manifestations as well. So things like POTS, etc. As soon as they start to lose their cardiovascular fitness, as soon as they start to lose their functional ability, those problems can become heightened as well, because you're just not able to have your cardiovascular system function quite as well when you've lost that fitness. So maintaining function early on is really important, and keeping them reassured that they're going to be okay with exercise and things are going to move forwards is really important. And picking them up early obviously helps that process. If they extend that out for years and years and years before they are diagnosed or before they're helped, and they have multiple dislocations, and they have multiple sets of painful areas, and they get very worried about every time they do something they get a dislocation or they get lots and lots of pain, then the whole cycle of things like persistent pain syndromes and so on and so forth become problematic as well, and compound the whole issue. So it's certainly something we shouldn't be dismissing, and we should be self-managing as best as we can with the help of the MSK therapist, and referring when we need to for those sort of medical inputs. That's Louise. Oh, we've got a follow-up bit. Louise has said, I see so many that are scared to exercise because of pain. Agree, can be very hard to manage. And this is one of the problems we have, especially with this cohort, is when they've had these symptoms for such a long time, they do become so fearful, and encouraging them to exercise at that point is so hard. And we need to, as soon as we start seeing them, encourage them early on to keep exercising and keep active. And it really, I've seen so many patients in the past where they had these symptoms as, a teenager, maybe young teenager, 14, 15 maybe, and they are removed from their PE sessions, or they stop doing their activities, and then you just see this decline off over time. And they've really got to keep their activity levels up. We've got to really keep them reassured that they will be okay if they stay strong and fit. This coming in a really late stage is so much more difficult, so much more challenging when they've got all those painful symptoms, they've got all that fear, and picking them up earlier is much better. And of course, when we do pick them up later, then we just really need to take a softly approach, really try to build them up slowly, and do it on their terms as much as anything else, so that they get a chance to accommodate to whatever they're doing, and then build up. And what we find is that a lot of people, they just have to go really slowly, and much slower than they may want to, for example, because they've got to accommodate to the increased activity levels, and then before they start building on top of that. And I just see too many people going too far too fast. Lovely stuff. So if we haven't got, we're just about running out of time. We've got a minute or so left before we run out of time. Any last questions, please do chuck them into the chat box and I'll try and get to them. Otherwise, I will answer them across social media. I want to direct you to my website, rheumatology.physio, with plenty of resources on there all about rheumatology. Recently released dates for my courses in 2022. I think there's one for Exeter, there's one for Birmingham, and there's a virtual one as well, covering all sorts of things about rheumatology, lots of recognition, and the in-person courses as well, doing some management stuff as well. Got some new tweaks I've made to that course coming up. The other thing that I've got coming up in January is I've completely created my online course as well. So the recorded online course, there's going to be more content, it's up-to-date content. And little plug here, apologies, if you were to sign up for my recorded course now, it will only be it's only £120. The price will go up in January, but if you buy it now, you will get upgraded for free in January to the new relaunched course. So that's worth doing, in my opinion. Obviously, I'm highly biased, having recorded all of it myself. But if you head to rheumatology.physio/shop, then you will find all of the links on there, the book, resources, those courses that I just mentioned are there as well. And please go check that out, and hopefully I'll be able to speak to you in person or online, and that is always my favorite way of doing it. So thank you very much for tuning in today. You can find, of course, all of my podcasts and blogs and stuff I record. Again, head to the website, you'll find that Rheumatology Physio podcast is there as well. Subscribe to that. I've got some really exciting stuff coming in January. Going to do a whole series on axial spondyloarthritis. Going to get some rheumatologists involved, get some really good in-depth information for us in MSK, so we really know where we stand on referrals, on management. I'm going to hopefully speak to A-Stretch about management, and we're going to get some really good information so that we can manage these patients as best we can. So I am totally out of time. I'm overrunning. Anybody that watches this show regularly will know that the music is going to be very, very loud in a second. So either mute me or reduce down, and I will see you soon. Hopefully, I might do another one of these soon. But thank you for joining in. Thank you for your questions, and hope you have a wonderful rest of the day.